Hello, interns. Having basic knowledge of ultrasound is going to be critical for your obstetrics rotations. Let me show you some of the basics so we can get started.
Most abdominal curvilinear probes for obstetric imaging are set to a frequency between 2 and 7 megahertz. Be sure to pick the correct probe before starting.
Today, we'll be using B mode and pulse Doppler mode. B mode stands for brightness mode, which is your basic 2D obstetric ultrasound image.
Remember, each transducer has a probe to help identify its orientation. The convention is for the probe to be facing the fundus in sagittal orientation and facing patient right during transverse orientation. You can move from sagittal to transverse by turning the probe 90 degrees counterclockwise. This will allow for correct orientation on the monitor as the probe corresponds to the left side of the screen.
Your resolution, or ability to tell two structures apart, depends on wavelength and frequency. Higher frequency yields better image resolution, but lower frequency is able to penetrate tissues more effectively. Therefore, at increasing depth, you lose resolution.
The depth knob allows you to increase or decrease the depth of the field. The depth should be appropriate to the tissue being imaged. An inappropriately large depth has the consequence of reducing image quality as line density decreases. The focal zone function optimizes the beam to suit a particular depth. This can be set to be done automatically. This optimizes the resolution at the desired depth. The gain knob adjusts the overall brightness of the image. The zoom function is used to magnify a region on the screen. The trackball is multifunctional and allows for measurements and scrolling back in freeze mode. The freeze knob allows the image to be frozen, which is useful in obtaining measurements.
Now we are ready to go over the steps of a basic level 1 ultrasound. This tutorial assumes a singleton pregnancy.
Place the transducer transversely just above the pubic symphysis and angle towards the cervix. A fetal head confirms a cephalic presentation. Presence of fetal buttocks and bladder confirms breech. A transverse lie requires further interrogation. Change your setting to pulsed Doppler mode. Place the cursor overlying the fetal heart. To document fetal cardiac activity, align the probe so that it is perpendicular to the long axis of the fetal heart. Measure the fetal heart rate from peak to peak. This will calculate on the top right of your screen. To assess, place the transducer in the sagittal orientation in the right upper abdomen just above the uterine fundus and scan longitudinally downwards towards the right lower abdomen. Repeat this same step along the left. Note that this patient has an anterior placenta. The placenta may be fundal, anterior, posterior, right lateral, or left lateral in location. The lower placental edge should be assessed.
If its lower edge is noted to be in the lower uterine segment or near the cervix, a transvaginal ultrasound should be performed to diagnose placenta previa. This is beyond the scope of this video. Amniotic fluid estimation can be measured using either the maximum vertical pocket or the amniotic fluid index. Today, we will learn using the MVP, since this is the easiest measurement of the two to perform, and it also has a lower false positive rate for oligohydramnios.
Begin by mapping the uterine cavity with transducer orientation in sagittal plane and perpendicular to the floor. Imagine the maternal abdomen in 4 quadrants and that you need to interrogate all 4. Begin by placing transducer in one of the quadrants and scanning in sagittal orientation. Repeat this step in all quadrants. Estimation of MVP involves finding the single deepest pocket of amniotic fluid free of cord and fetal parts. In order to be a measurable pocket, the width must be at least 1 centimeter. A normal MVP is between 2 and 8 centimeters of depth.
4 fetal biometric measurements are required to help establish fetal weight as well as the EDD. These include biparietal diameter, head circumference, abdominal circumference, and femur length.
EDD should not be adjusted if an earlier ultrasound has already established dates. Please refer to the Ultrasound and Pregnancy Practice Bulletin for specifics on dating.
Fetal weight can be calculated using the predetermined formula which is programmed into your ultrasound.
The biparietal diameter should be measured in a cross-sectional view at the level of the thalami. Sonographic landmarks for measurement of BPD include thalami, symmetric appearance of both hemispheres, cavum septum pellucidum, midline falx, and insula. Make sure that the image is zoomed in so that the cranium fills the screen and there is very little dead space surrounding. Cerebellum should not be visualized in these images. Freeze your image. To calculate, hit the Calculate knob and select the BPD option. Position the first caliper at the outer edge of the parietal bone at the level of the thalamus where the head is widest and set it. Position the second caliper at the inner edge of the distal parietal bone to draw a perpendicular line to the midline falx. Ensure BPD is as wide as possible and perpendicular to the midline falx.
The head circumference is measured in the same view as the BPD. The ellipse method of measuring is our favorite method as this has the least error. Of note, this measurement is taken from the outer to outer parietal bone, unlike the BPD.
To calculate, freeze your image and this time select the head circumference option. Position the first caliper on the outer edge of the parietal bone and set it. Position the second caliper on the outer edge of the distal parietal bone to create a perpendicular line to the midline falx and set it. Open up the ellipse by rotating the trackball until the ellipse is laid perfectly over the cranial contour. If the ellipse is not aligned with the fetal head, change the position of the calipers, which act as hinges. The abdominal circumference is measured as a transverse section of the fetal upper abdomen. Landmarks include circular cross-section of abdomen, spine seen on cross-section, stomach bubble, intrahepatic portion of umbilical vein, and fetal ribs seen bilaterally in their entirety. The AC is best measured with the spine at 3 or 9 o'clock as it can cause shadowing in the 6 and 12 o'clock positions. Again, make sure the image is zoomed up and that the AC fills the screen. Fetal kidneys should not be visualized in the AC measurement. Freeze your image. Activate the Calculate or Measurement knob and select AC. Position the first caliper on the outer surface of the skin line, roughly at level of rib end, and set it. Position the second caliper at the distal skin edge such that a perpendicular line is created between the 2 points with the midline. Open up the ellipse using the trackball such that the ellipse is laid perfectly over the skin contour. In order to measure femur length, the longest visible diaphysis of each femur should be measured by placing a caliper at each end and excluding the distal femur epiphysis and any distal spur artifacts which may falsely lengthen the femur. The femur should be horizontal across the screen and the ultrasound beam should be perpendicular to the femur. Again, the image should be zoomed up so only the femur is seen. When ready, freeze your image and select the Calculate or Measurement knob and this time select FL. As you can see, now that we are done with our ultrasound tutorial, our patient is ecstatic with her images.